So yes, the title of my talk is Progress in Prostate Cancer Grading. And the first question is, progress? How could there be anything progressive about something as boring as prostate cancer grading? But I contend to you that one of the most important things that we do as pathologists is make sure that the grading schemes that we use and why we use them are up to date and relevant. And that is really what we're talking about today. By way of disclosures, my disclosure with the 3D biopsy company has nothing to do with my talk, but that's there for completeness' sake. So we talk about prostate cancer grading, or grading in general, any cancer in grading. What we're asking is really the phenotypic expression of the degree of invasiveness or aggressiveness of the tumor. So it reflects the degree into which cancer cells deviate from normal. This goes back all the way to Broder, who first described a grading system for cancer of the lip, denoting that if you grade something, the farther it deviated from normal in terms of cell-to-cell interactions, invasiveness, and morphology, the more likely it was to kill a patient. And it's directly proportional to the risk of metastasis. There have been a number of grading systems for prostate cancer that rely either on nuclear features, like most grading systems for other cancers do, and also architectural. The one that has really stood the test of time, as you know, is the one by Don Gleason. And this really represents the 50th anniversary of his hallmark paper back in 1966, which was based on a relatively small number of patients at that time, about 270. What Gleason did was really kind of astonishing. He was an artist, and he liked the patterns that he saw as a pathologist looking through the microscope at prostate cancer. And he denoted, man, there are a lot of different patterns of injury. Architecturally, this is a very interesting tumor. And so he drew them out and recorded them, and he looked at outcomes. He gave them all to the statisticians. He says, does the architecture of the tumor mean anything? And it turns out it did. And what he was basically drawing when he did this architectural framework over here was two key features of prostate cancer. One, its morphologic resemblance to normal prostate, and two, its degree of invasiveness. So if you look down here at what he called Gleason pattern 1, he was composed of these small rings of really well-formed acini lined by cells that looked for all the world like normal prostate cells and had this nice rounded border indicating that it didn't really invade very well. It just kind of grew as a solid mass. All the way to the other extreme, which showed total anarchy in terms of the cells. They form sheets, individual cells. They can't cooperate with each other at all. They don't make glands, and everything in between. And he also said, well, prostate cancers rarely show one pattern by themselves. They're usually a combination of patterns. And they behave like those combinations of patterns. And so that's the well-known Gleason score, which originally was the most prevalent pattern and the second most prevalent pattern added together. So if you had a lot of this and a little bit of this, you would call it a 3 plus 4 tumor, or score 7, out of a possibility of 10. Because if it was pure, you just double the number, 1 plus 1 or a 5 plus 5. What is not very well known is that Gleason himself did a whole lot of refinements to his Gleason grading system over the next almost 30 years. The first that was published was in the 70s when he really showed that the system worked. By this time he had done this in over 4,000 patients, and it really held up prognostically. And he also redefined some of the criteria for pattern 4. And then in 1992, he came up with the subdivisions of patterns, different looks within things that we still called Gleason grade 3, for instance, 4 and 5, cribiform patterns 4, and all of these other things got added into his Gleason grading system. And this is the well-known blueprint, if you will, for patterns of prostate cancer, and it was published in 1992. I want to add some attention to two features of this. The first is right here, and it's this dividing line between pattern 3 and pattern 4. For those that really catch it, you'll notice that the same pattern or look of pattern bridges that boundary. So that's a problem, because you'll have something that looks like these fused glands here. Well, is it a 3 or is it a 4? You have these cribiform arrangements, and I'll tell you what cribiform is in a minute. Are they 3 or are they 4? And the clear answer is that Gleason himself wasn't sure. And so we'll come back to that. And what we've noticed since the time of Gleason is really the business end of this Gleason grading system is down here. These patterns 4 and 5 represent the most aggressive variants of prostate cancer and the things we really need to pay attention to. And so if you look at mortality data, and this is good, this is across 5 institutions, almost 24,000 patients treated by prostatectomy by age here. These are the different age groups, 60 to 69, over 70, below 60. And you'll see that Gleason grade 6 or score 6 tumors do extremely well. And as the relative proportion of the high grade increases, namely 3 plus 4, 4 plus 3, or 8 and above, that mortality due to prostate cancer per se, in the black part here, increases proportionally as well. So again, the business end seems to be in patterns 4 and 5. But there were problems with the Gleason grading system. And we've learned these over the years. We have new tools now. We have things like basal cell cytokeratins that are available to us as pathologists. And we found that a lot of these things that were called pattern 1 actually had intact basal cells, they had intact basement membranes, they weren't really invasive tumors at all. They're recognized now as benign. As I pointed out in the early grading system, there was confusion on what to do with some of the patterns, particularly the so-called cribiform pattern, which I'll talk about in just a minute. Certain variants of the cancer, like mucinous cancer, ductal cancer, weren't even described in the Gleason grading system. We don't know what to do with those. And of course, there are tumor sampling issues, and we can't get away from these, and we'll talk about more about this at the end of the talk. He himself noted that prostate cancer was heterogenic, and that you could have different patterns within it. And with small caliber needles used for biopsy, you may only sample one pattern. So in 2005, the now famous meeting between the International Society of Urologic Pathologists, or ISUP, met to discuss these issues and really provide some guidelines for grading for the community. Now, there's been a lot of talk that this was an attempt to redefine a new grading system for prostate cancer. It wasn't that at all. It was basically to ask experienced genitourinary pathologists their experience on the Gleason grading system to provide guidelines accordingly. So it was based on data and experience. So the recommendations then were really based on the grading practices of these experts at the time, rather than a new ploy to get a new grading system per se. And we were really talking about modifying the Gleason system. And the first thing we discussed was this restriction on assigning low grades, patterns 1 and 2, to biopsies, recognizing that many of them were benign, or at least they would be upgraded at the time of prostatectomy. So it wasn't a good idea to really call them that on biopsy. And again, this is not something new that we just suddenly decreed. If you actually look at the capture data, before the meeting even started, you could see that the relative proportion of tumors that were graded as Gleason patterns scores 2 through 4 fell from about a third of tumors all the way down to almost about 5% by the time the meeting had begun. So this was indeed happening across the world, actually. So we also discussed the cribiform issue, but we couldn't come to a consensus on the cribiform issue because really nobody had any data on it. And so it was left that we would say, well, if they're large and irregular and nasty looking cribiforms, we'll call them grade 4, but if they look small and round and not so nasty, we'll call them 3. Boy, that leaves a lot of interpretive ground in there to handle how to do that. So we'll come back to that in a minute. We talked about grading histological variants. I won't talk about this too much today. Certain things like ductal carcinomas did show good data in terms of outcome, and so it was easy to categorize them. For instance, ductal is a grade 4. And then one of the things that probably caused most concern and controversy was what to do with minor amounts of high-grade tumor on biopsy. The original Gleason system just looked at the most prevalent and second most prevalent. And by the way, there was a comment made that if it was less than 5% of a pattern there, you should ignore it. And there was really no data to suggest that. And now there is data, and at that time there was data. And so we made some recommendations on how biopsy should be scored. So a minor secondary component of a higher grade, even if it's less than 5%, should be included in the Gleason score. So if you're greater than 9%, 3, and less than 5%, 4, it would be a 7. But you wouldn't do that the other way around because the high grade component trumps the low grade component. So if it was greater than 90%, 4, and just a little bit of 3, ignore it, call it an 8. And then even more striking was if you had 3 patterns and the highest grade wasn't one of the top 2, then we should still include it in the Gleason score. So 70% pattern 3, 25% 4, and 5% 5, that should be graded as a 3 plus 5, not a 3, 4 like the old system said. Was there any data to support this? Actually, there was. This came out of Johns Hopkins, showing that if you looked at what we call tertiary, very little, less than 5% of a high-grade pattern, in something that would otherwise be graded as a Gleason score of 5 or 6, that they behaved more like 7s on outcome. So it should have been included in the score. And if you look at Gleason 7 tumors that had a tertiary less than 5% of a pattern 5, they behaved more like Gleason 8s. So it should have been part of the score. And so that's one piece of data. And then Stamey's group, the other coast in America, said the same thing about the same time, and showed that really it's the relative proportion of patterns 4 and 5 that are the business end of the tumor, and the fail rate for therapy increases as the prevalence of pattern 4 and 5 increases. The concern was that this was going to cause an elevation in Gleason scores, that we're going to have a grade migration, and indeed that did occur. And if you look at, this is a study in which the same pathologists looked at how they graded prostate cancers before the meeting and after the meeting, and you can see that there's a migration of Gleason scores of 6 or below into the 7 group, and that this was due primarily to reassigning the secondary grade, meaning that the highest grade was in there. So there was a grade migration. Now we've been accused of saying what you did here was essentially lower the stringency for calling things high grade, patterns 4 and 5. I will argue that that's not the case. What we've done is increased the stringency on what we call low grade, and that was intentional, and I'll show you why it's important at the end. It was important, though, to really understand, did this change anything? Was this a relevant practice? And this is, again, Johns Hopkins data that looked at grading tumors using the 2005 modified Gleason scoring criteria. I lost my mouse. All right, I'll use the pad. Oop, I don't have it on here. It's soon.
Could I just ask a question?
There it is. Yeah.
Can I just ask a question while you're doing that? So the tertiary pattern on the modified Gleason, was that based on the original biopsies or on whole mounts of the prostates after they were removed?
That was actually prostatectomy data right there. Stamey's work was also on prostatectomy data, looking at tertiary rather than biopsy.
So has anybody looked at it in terms of the biopsy?
Yeah, we have, and it also applies in the biopsy. The problem is that if you look at biopsies from 15 years ago, the caliber of the needles were different. And so we actually did get tertiary grades, not uncommonly on those biopsies. It's actually rare to get a tertiary grade on a needle biopsy with an 18 gauge barred driven gun. It doesn't happen very much because the amount of tumor sampling is much smaller. So what we saw here, we looked at it and said, in some of the higher gauge needles that we saw 15, 20 years ago, it was about 10% of cases had a tertiary. Now it's about 1. So it's really rare to actually see a tertiary pattern on a biopsy.
So you can't really make clinical decisions based on a tertiary pattern?
And not on biopsy, not so much. So it just doesn't, it's not as much of an issue now with the smaller guns. So here again, here's the Johns Hopkins data looking at that, and you can see that if you look at a Gleason score 6 using the modified 2005 criteria, that this is on radical prostatectomy and biopsy at the top, you can see that biochemical recurrence is relatively rare. So these do very, very well. And as the relative proportion of patterns 4 and 5 increase, this is 3 plus 4, 4 plus 3, 4 plus 4, 8, and then Gleason scores of 9 and 10, that the the recurrence rate goes up accordingly. And if you look at multivariate analysis, they showed very nicely that grade increased the hazard ratio for biochemical recurrence as you progressed up the scale, as it were. This is a great study out of the Harvard group looking at original source grading versus standardized review using the 2005 modified Gleason scoring system. And what you see is they rescored these. And you can see that by rescoring, less than 1%, there's over almost 700 patients, less than 1% of cases got graded as Gleason scores of 2 through 5 with the 2005 modifications, whereas it's over 20% of the original biopsies were scored this. But look at the mortality rate. This is prostate cancer specific mortality. You can see the person years of follow-up here. There was a very low but still real mortality rate of Gleason scores of 2 through 5, and a little over 1% for those scored as 6, where with the new stratification there were 0 deaths. So we're actually, again, causing more stringency on what we call low grade for this reason, to really identify patients who are very unlikely to progress or die from their prostate cancer. Why is this important? Because nowadays, what used to be important about grading a tumor at all was after treatment, what is your prognosis? If you found cancer, we treated it definitively. Now we're talking about expectant management, active surveillance, not necessarily treating a tumor. We really want to identify those patients who would benefit the most from not being aggressive. And so this, bringing the mortality rate down to essentially 0, was an important concept. And you also look at the hazard rate for death here, and it's all over the place. In fact, here the 4+3 was worse than the 8, and not so here. So it seems like there was contamination early on, and the modified Gleason grading system really improved that. But we couldn't leave well enough alone, so the ISUP met again November of 2014. This time there were 85 GU pathologists from around the country, around the world actually, and we invited clinicians to this, including urologists, medical oncologists, radiation oncologists from around 17 countries. And what the purpose here was to address some issues that were either left unaddressed back in 2005 or that needed reconsideration because we had new data. For the pathologists, we had to do some clarification on how to classify some of the morphologic patterns. I won't talk about that so much, but I do want to talk about 2 other things that were brought out of this meeting. And the first was the grading of what I've called cribriform and what we call glomeruloid patterns as pattern 4, and why the data really indicated that these were more aggressive and high grade. So I use this term, and what am I talking about? Okay, I've been challenged by urologists to try to get all the way through a pathology talk without actually showing pathology. I did close on this. This is the only pathology I'll show you, but I couldn't help myself. So what we're talking about, this was the old small cribriform, which would be called pattern 3. It's much higher power than these other photos. And these small rounded nests. Cribriform refers to sheets of tumor cells with these punched out holes. So it looks like you went in with a hole punch and just punched holes out of these sheets of tumor cells. And that's a term that's been given to these as cribriform. These larger nests were called pattern 4, but again, no data. And what to do with these things? These are sort of cribriform, but they also get into these clefts here that make them look like glomeruli, so they call them glomeruli. And we had no idea really with data what to do with these. Well, this is a study we did out of our institution. I know it's complicated and a lot to look at, but what we did here is an image analysis study defining these areas, drawing them out, actually showing the percent of the tumor that was involved in these, and then looking at outcome. An outcome here was biochemical recurrence after 5 years. And I've outlined cribriform. And what we see here is that cribriform behaved badly. The odds ratio is anywhere from 5.5 to 6 in terms of PSA failure here. And it didn't matter how big or how small the cribriform nests were. They were equally bad. And so breaking it down into small versus large made no sense whatsoever, at least in our opinion. Another study, probably a better study. Yeah? We did. This is a multivariate analysis that excluded the fact that many of these did have other patterns in them to really look at it. So it was well controlled for that reason. This is, like I said, probably an even better study. This is a study out of Australia that looked at just Gleason 7 score tumors with or without cribriform pattern. And what they found, regardless of the amount or the size of the cribriform pattern, if it was present, then you had an 8-fold increased risk of metastasis and a 5-fold, almost 5.5-fold increased risk of death due to prostate cancer if that was the case. In other words, just having the cribriform focus was a bad prognostic sign, and therefore we should not be including this as a Gleason pattern 3 at all. And so we redrew, if you will, what Gleason originally proposed in 1992, and this is what we've gotten criticized for, is that we've redrawn the whole Gleason grading system. Yes, well, we did. But we got rid of this vagaries of this borderline between 3 and 4 and put all of these things that were fused back into pattern 4 because they do behave badly. And what the dividing line here is really discrete now to show that anything that's called low grade has to do with those tumors that make acini that are well formed and separate, more like normal prostate than these other weird architectural patterns. Yes?
You suggested from the Australian study that there is no quantitative aspect to it.
No, even small amounts of cribriform were doing it.
It's not a continuum.
Oh, it probably is, but for in their data, even those with less than 1% of it having cribriform,
they would do just as badly as someone has 90%.
yeah, but their numbers were small enough that they had to bunch them. So we can't really answer the question: is there, should we be doing the percent of cribriform cancer? By the way, I actually do in mine. In my reports now, I'll actually say, 4+3 tumor with 35% cribriform morphology, because eventually we'd like to be able to answer that very question.
But right now, your clinicians can't.
Right now, it's all batched as a dichotomous variable, present or absent, we know about. So these cribriform arrangements and anything that is not well formed really fall into this lower category here. Again, with the idea of better stratifying those patients who are likely to do very well versus those who are likely to progress. Now, more controversial is what we did here, and that was the attempt to get a new prognostic grade classification, still based upon the Gleason patterns, but that meant more to patients and clinicians. Here, the concept is really this. In today's era, does it really make sense to still use a Gleason scoring system that ranges from 2 to 10? I've already told you that a lot of the low-grade patterns were benign. With the modifications to the Gleason scoring system, Gleason 6 has favorable outcome. Yet, if you look at it, Gleason 6, according to patients, is halfway between 2 and 10. Why are we calling that low grade? It's intermediate. It's somewhere in the middle. Gleason 2 and 5 are not used very much, not prognostically different from Gleason 6, and as I've already stressed, it's the amount of patterns 4 and 5 that are most important for prognosis. So, and really the idea of grading has changed here. We're grading biopsies in a meaningful way because we need a grading system that can identify those patients that would most benefit from active surveillance from those that need immediate treatment of some type. And so it's kind of a different purpose than we had before. And I go back to this. We've seen this data before. Are these tiers meaningful? Well, it looks like anything 6 or below does really very well. And as we add these different tiers, 3 plus 4, 4 plus 3, 4, 4, and 9 and 10, that these do well at stratifying risk here. So why don't we adopt those? And we talked about adopting Gleason scores as 6 or below as prognostic grade group 1, the best grade group in terms of prognosis. 3, 4 is 2, 4, 3 is 3, 8 as 4, and 9 and 10 as prognostic grade group 5. This was overwhelmingly supported, 90% consensus, including the clinicians. In fact, of the clinicians, there was 100% consensus. And it also was recommended that we could add the percent of high grade or pattern 4 in these prognostic groups 2 and 3. But importantly, all modifications that we had talked about so far to the Gleason system should be used in the classification, again, to make these as pure as possible. So since then, we've had some validation studies. This is a multi-institutional study here by groups in Europe and Australia. And you can see that if you look at the ISUP 1 groupings, so this is prognostic grade group 1 all the way to 5, this is scoring on biopsy and results of the pathology at prostatectomy. And you can see as you go up, you have in score here, you have an increase in extra prostatic extension, which is light gray, seminal vesicle invasion, which is dark gray, and lymph node involvement, which is red here. And importantly, the ISUP1 tumors had very little extra prostatic extension and no lymph node involvement or seminal vesicle invasion. And here's the hazard ratio for biochemical recurrence with the different grade groups. So it really validated that that tiered system works quite well. And this is from the RADAR study, radiation study, also looking at the ISUP scores in here, looking at metastasis and cancer-specific survival. You can see that if you're ISUP group 1, there were no metastases and no deaths at 7 years in that grade group, and it went up proportionally as you went up the tier. Yeah.
So one thing that are really important, I guess one thing that isn't incorporated is volume. And so was there a discussion made about how to incorporate volume into these groups?
Yeah. It's still considered part of the NCCN. We didn't really change what the NCCN guidelines were, so we kept the idea that you should look at extent of tumor by number of cores positive and by percent of cores positive to really classify it as NCCN. Because if you didn't, the NCCN wouldn't know how to classify it. So it is still in the reporting mechanism. This is just about grade, but it's still in the reporting mechanism. But we should also include how many cores are involved and what percentage of each core is involved in there as a means of showing extent of tumor involvement. So still calling something very low risk tumor still has to do with Gleason 6 or what we would call ISUP 1, but it still has to be less than 3 cores, no core greater than 50% positive. Does that answer the question? So we didn't actually change the guidelines on reporting extent. In that same study, they actually looked at grading the tumors by the 2005 criteria and then adding the 2014 criteria and showed improved concordance index by using the 2014, statistically improved over even the 2005.
Would you intuitively think that, going back to my question about quantitative grading, that in that 4+3, there would be a difference?
What it really comes down to,
4+3 can be 60 or 70 or 80% of 4. Is there a difference? And also in the 8s, that you just told us that a 3+5 is an 8.
Is an 8. It's an unusual pattern for an 8. Most of the 88% in our database, 88% of 8s are 4+4.
I mean, from a clinical point, it doesn't make a big difference.
Yeah.
Sitting in front of a patient,
you're still treating.
8, you got bad disease.
So we haven't answered the question on, that was why it was recommended that we do the percents, because what we haven't answered the question is, if you've got, more important to in the discussion was, if you've got 40% pattern 4 versus 60% pattern 4, then you've actually changed the class, right, from 3+4 to 4+3. Does really 20% of your biopsy really warrant that? And we don't know, and that's why we've got to capture the data.
What that leaves out is the denominator of volume.
Absolutely. And in my opinion, the most important thing that we could report, if we could, is the absolute volume of pattern 4 and 5. Forget the 3. If we could actually do that in some way, if we had imaging that could actually tell us you've got this volume of patterns 4 and 5, that would trump everything.
Back 30 years to Stamey. He was 30 years.
He was right.
Yeah.
I say that really begrudgingly too. From a genetic point of view, it has also been validated. This is Mark Rubin's data, looking at 426 prostate cancers and looking at copy number alterations, either deletions in blue, amplifications in red. And what you see is across the different grade groups, so this is prognostic grade group 1 all the way to 5, that the same pattern of changes does occur, but with increasing prevalence as you go from low to high grade. And it says a couple of things to me. Not only does this really stratify patients appropriately, but it also tells us something about these ISUP1s. They're cancer. And we should probably think of them as cancer. There's this move to say, is Gleason 3, pattern 3, really cancer? There's data to suggest it is cancer, but it's very low grade. It is an indolent cancer. This particular one's probably not going to kill you. This one will. So in summary, and I'm not done yet. I just want to say where we are here. In summary, cancer grade is still one of the best indicators for prognosis that we have. But a grading system nowadays should be able to tell us which tumors are most appropriate to treat and which can be expectantly managed. The Gleason grading system itself has undergone a number of refinements, and that the new 5-tier prognostic grade groupings proposed in 2014 by the ISUP offer excellent prognostic stratification. They're still based on the Gleason system, but they're easily understandable, and validation studies have confirmed clinical utility. Let's go back to this problem. And this is reflected in what you had to say here. Is we are sampling a very small proportion of the prostate with our standard biopsy protocols. How reliable is it to say what the prognosis for the prostate is when you have a sampling issue going on? So there are some issues that we need to think about when we have a biopsy with tumor on it. Prostate cancer is a multifocal disease. In our experience, a little over 80% of cases that go to prostatectomy have more than one tumor focus. Those foci usually differ in terms of grade, and even within the same grade can differ. Tumors can also arise as high-grade foci. This was first done by my mentor, Gary Miller, back in 1994. He showed that you can have very small tumors arise as high-grade lesions. They can start out of the box that way, or of course they can transition from low-grade. And tumors may not develop concurrently. We think that all of cancer that you're going to have is happening now at the time we biopsied, but if we leave a prostate in, there's the chance that a high-grade focus could occur later. Cancer sampling is a function of the tumor volume to prostate cancer volume ratio. The bigger the tumor in a smaller prostate, the more likely you are to hit it with a needle. Small tumor in a big prostate, less likely. Similarly, if we removed all the low-grade component and just look at high-grade, sampling the high-grade tumor is a function of the volume of the high-grade tumor to the prostate volume ratio. So you can miss it. And unfortunately, biopsy may not sample the highest grade. And of course, biopsy is a parable staging tool. Best way to look at this is what we do at our institution. We do whole mounts. I know you do them here too. This is what we do. We cut the prostate from apex to base every 4 millimeters. And then we take these, put them on large format slides, draw out grades, areas of extracapsular extension, etc. Then we draw these onto acetate maps. We scan them, go through a number of conversion steps in the computer, eventually to make a three-dimensional reconstruction. And what you have here, the cloud here is the prostate itself, and I've got some things highlighted. The blue is actually the urethra, showing the usual little 45-degree bend in there. And there are two tumors. This one is in the transition zone, and this green one's out here in the peripheral zone. So multifocal lesion. Here's the different one. We've done over 600 of these. This was one pulled out at random, but it really was enlightening when I pulled this one out and said, oh, I like this one because this is very informative. This is a more solid voxel-based diagram of it. I took away, whoops, take that back. I took away what's normal, and in this particular prostate, we've got 5 foci of tumor. The different colors indicate the different grade patterns within them. I happen to know that red is pattern 3, green is pattern 4. This is the rectum back here. This is the base of the prostate, anterior and apex down this way. And so if we were to biopsy through the rectum and hit it in various spots, we would say things differently, wouldn't we? This one we would call a 3-3 tumor. This one we call a 3-4 tumor, and this one a 4-4 tumor right next door. So where we hit it matters. Oh, and by the way, none of these biopsies in the posterior region sampled this tumor in orange, which is actually a pattern 5, Adenocarcinoma here. So this is 5+5 tumor right there. And that probably has more to do with the outlook of this patient than any of these other things that were not sampled. Which would you call the index lesion here? It's an interesting question, right? For those that say index lesion is the highest volume tumor, well, it's just 3-3. Actually, it's a 3-4. There's a little bit of 4 in there. Others would say, well, this, on biopsy at least, this would have trumped this. This is the index tumor. Actually, that's the index tumor. This is the highest grade tumor, and it's a significant volume. That's a cubic centimeter 5+5 tumor. So these things are issues, and they do come up. And if you look at the SEER database, you see why still on those biopsies, Gleason's 3+3, a number of them are upgraded at the time of prostatectomy. And a number of them have advanced stage at the time of prostatectomy. So there's a certain amount of uncertainty with the biopsy. And here's answering the question, looking at limited biopsy. These are all NCCN very low or low risk patients, meaning not only did they were they ISUP 1, but they also had a limited amount of tumor, either less than 3 cores or no tumor greater than 50%. And you can see that depending on the study, anywhere from 15 to 50% of tumors were upgraded at the time of prostatectomy or upstaged and were non-organ confined, anywhere from 3 to 10% or so. So there's a very real risk that we're undergrading and understaging. So that brings the concerns. How can we actually and accurately assess tumor grade and aggressiveness with just a needle biopsy? Can we truly identify those tumors that are insignificant and unlikely to progress? Fortunately, there are those of you, and I had a great day yesterday meeting with Tim and Guy and really looking at solutions to this. We need to improve our imaging. Multiparametric MRI is a step in the right direction. It can be improved even more to pick up smaller lesions. What we do is this archaic thing at University of Colorado called a transperineal template guided mapping biopsy. This is an archaic, barbaric thing that we do to patients. So we take a brachytherapy template and we biopsy every 5 millimeters in every direction, coming up with 90 or so biopsies, and then you can do a reverse reconstruction and really look, and they're very accurate. We've found accuracies extremely high when compared to prostatectomy.
Remind us of the cost of it.
Well, but the cost is ridiculous, and nobody pays for it, right? Nobody's going to pay for it, so the cost is high. You have to go to the OR. You have to be put to sleep, so there's that risk involved in it too. So this is not really a practical method. Now, more people are using biomarkers, and that's what's really taken off in terms of studies looking at biomarkers. And in fact, some of them are commercially available. I'm not going to get into biomarkers here. That would be another hour talk. But this happens to be Oncotype DX, put out by Genomic Health, looking at the NCCN guidelines and the likelihood of favorable pathology, meaning less than or equal to 3-4 an organ-confined disease. And what we know historically to be the risk. And if you add in their gene expression profile, the GPS score, you can better stratify these as to cases greater than 90% likelihood to almost the same as an intermediate tumor. And you can do the same with all the other risk groups. So adding this data might help us to better choose which patients are our best candidates for active surveillance. And we're going to see more and more of these come up. I mean, in the last 5 years, we've seen 5 different commercially available markers, and more are on the horizon.
You're still assuming, though, that the GPS on that, going back to that example you showed us, somehow that one needle is going to predict for
right. So I won't get into, I don't want to get into how this was designed, but they actually took that into account a little bit. And they, what they were looking at are markers that could tell us, even if you sampled a certain area of the prostate, that somewhere in the prostate was a higher grade lesion. And so it wasn't necessarily sampling the higher grade lesion. Now, I'm a little bit skeptical. However, it does seem to show, it does seem to stratify patients better than what we have with just grade alone. And so I think it does have a role. The question is how acceptable and how validated that role will be, and we'll know better in 5 years when we get the data. But this is where I think we're going. Currently I've talked today about grade, but grade and extent is still the most important things that pathologists can tell you about your tumor. And of course you add in your clinical factors, and probably PSA is going to fade away here, and we're going to see 4K, and we're going to see other things probably take its place. But the future is probably now. We're starting to see more molecular profiling, mutational analysis, and these things are going to be added in to really calculate a risk of progression that will govern whether or not these patients should be managed more conservatively, or they should have treatment, and what kind of treatment, what definitive treatment are we going to recommend. And I think that's what's going to happen in the next 5 or 10 years, and where we're going with this. I don't think I'll be out of a job, despite what Tim and company are doing. I don't think I'll be out of a job, but I think we could do a better job of making sure that we grade these tumors appropriately and better stratify these patients. Thank you. I'll stop there.
I remember at the dawn of the enthusiasm of genomics that many genomicists were predicting that pathologists would no longer be needed. But, 15 years later, pathologists are now needed much more for the genomics than ever before. So thanks, Scott, for that great and very informative and instructive overview. Questions for Scott? Well, people are thinking I do have one, and one of the issues is one of the problems with sampling, which will always be with us, is whether or not we can address the challenge of undersampling by looking for instructive information in the stroma. Which,
and I think there are groups that are actively looking at that, and there's some interesting data looking at gene expression profiling in stromal tissue in patients with cancer versus those without cancer. And we just saw a grant funded by the DoD that actually is looking at doing stromal grading. Stromal grading of tumor. They look at the stroma around the tumor and can tell you more about how the tumor is going to behave than looking at the tumor itself. So that'll be interesting to see what those results will be.
There's a genomics assay called it's a methylation assay, that if several genes are methylated in the stroma, it predicts for exactly what Larry was pointing out, or you were with undersampling. So stroma is important.
Well, one of the continuing challenges of Gleason scoring is the subjective nature of our starting point. And, have you looked at the degree of concordance between the needle biopsy and prostatectomy in terms of the grade? How much of it has improved with our improved refinement Gleason scoring criteria, and whether that concordance changes much depending on what the original score was on the needle biopsy. In other words, is a 3+4 was a concordance with the radical prostatectomy versus a 4+3, and that seems to be quite a critical juncture. And kind of as part of that,
they go both directions.
Question: is there an amount of lesional material that you find where the concordance really deteriorates? In other words, is there a small amount of lesional cancer material where assigning a Gleason score is a bit problematic when you've got 0.2 millimeters of one core, which we can diagnose as cancer, and then we give it a score. We might even give it a 3+4 or 4+3.
So I don't have my own data on this, but what we have found is if you've got less than a third of a core that you're using to grade, that the concordance drops more proportionally than if you've got more than half of a core involved. So if you look at the two polar ends, actually we divided our cores into thirds when we did this study, and it's in our PCPT data actually. We just didn't stress that, but we divided it up into an extent was called a 1 if it was 1/3 or less, a 2 if it was 2/3 or less, and a 3 if it was more than 2/3. And if you look at the concordance when we did our PCPT correlation with prostatectomy outcome, those that had less than a third versus, we did the two tertiles, those that were less than a third and those that were more than 2/3, big difference. The if you had more than 2/3 of your core involved, then the discrepancy rate was around 10%, little over. It's like 12% of those got upgraded. If it was less than a third, it was closer to 50%.
Do you put a qualifier in your report?
I still do put the extent, and that is my qualifier. You know, every core. First of all, when we do our reports, we do not combine cores, like is a practice on the community a lot. Is you
report
each core is reflected, and we'll say, you know, you've got a 3+4 involving, and we'll actually put, you know, 1.2 millimeters, parentheses, 11% linear extent of one core, and so we'll put that in there. So you'll have that data available when you do it. But certainly that is true. What we have found is with the modified grading system, our correlation with prostatectomy results has increased substantially. We were close to 50% upgrading from biopsy to prostatectomy before the modified Gleason grading system. Now we're down to about 18. Still not perfect, but a heck of a lot better.
Larry, then Ryan?
You sort of glossed over a little bit on the introductal variant.
Yeah.
In the breast cancer world, there's a huge difference between introductal and acinar.
Yeah.
Can you comment on your thoughts on that for the prostate?
So introductal carcinoma there have been no good examples that I could find with any of my GU colleagues that show just introductal carcinoma. PIN for sure, but introductal carcinoma where you've got a marked atypia, you've got necrosis in introductal necrosis going on, and yet still an intact basal layer by itself doesn't occur much. When it's seen with cancer, it's almost always seen with high-grade cancer, Gleason patterns 4 and pattern 5. So what we feel is that it's mostly that the prognosis for introductal carcinoma is really driven by the 4 or 5 cancer than by the introductal component. The introductal component is interesting because it's telling you you've got introductal spread of tumor.
So it's not just an issue of, you know, your thin slice and you may be missing a lot of introductal and not calling it.
Yeah, I don't. It just doesn't get called. It doesn't get called as much. I mean, because it gets trumped. So you could ask. You could also make the comment that we really haven't studied it well to see if it adds any more prognostic over a 4-5 by itself. But right now, you know, it's a marker that you've got, you know, bad disease. What I have done, I had a biopsy recently where it was wall-to-wall introductal, and I called it introductal. It was not PIN. It was introductal carcinoma. It was nasty tumor, but I didn't find any invasive component on the biopsy. And I said, you know, this is introductal carcinoma. Very high likelihood that you have an invasive pattern 4, pattern 5 somewhere in the prostate, either rebiopsy or this needs to be followed very closely.
That's distinct from ductal because it's...
Ductal carcinoma is a morphologic pattern. That's ductal carcinomas, by the way, arise more from the central zone of the prostate, which is derived from Mullerian duct. So it looks more like endometrium.
And it's non-AR driven?
Good question. I don't know the answer to that.
That's
I think it's
most of the time PSA
and
is
PSA is very
it's
it's low on those, so
non-responsive
they
to
don't
ADT.
they don't make a lot of PSA. I just don't know what their AR status is, but they look very different. They look like endometrial carcinoma, and they're very aggressive, very nasty.
The slide on the sequencing for the 3, 4, and 5s. For some of the ones in the middle, like stratifying the 3+4, 4+3, do you think it's practical to do sequencing as an additional measure for prognostication off of a biopsy specimen?
I don't think it's practical. I think it's something that we should probably study and look at. But from a practical point of view, I think a lot of your are you ever really on the fence on those?
Oh, why? I think that, you know, an aspect of the future is single cell sequencing. I mean,
Yeah.
you know, for
It's just not
evolution,
practical
but-
right now.
But it will. I mean, as costs come down, and you are going to be able to pluck these out and look for copy number abnormalities that will be.
Yeah. In our institution, 3/4s are considered not very aggressive as long as it's 1 or 2 cores. When you get past that, and a 3-4 is considered as bad as a 4-3. And again, I think it's the absolute volume of the 4 that we'd really like to know.
There are groups looking at the question of what pattern. Once you're pattern 4, you're bad usually. But are there patterns 3s that behave like patterns 4 that can be identified genomically? And I think that's what a lot of
I think that needs to be done.
Are looking at.
The molecular profiling of small volume cancers versus large volume cancers, how does that compare, say, when you have a large volume 4 and a small volume 4? Because you can have a very small volume 4 tumor, which presumably is clinically significant, but we often say that the clinical significant volume is 0.5 cc. You do see occasionally very small volume high-grade tumors.
Right. I don't have the slide here to show you, but what you'll find is within these large volume tumors, groups that have done sequencing of various areas have shown almost genetically distinct clones within them. And it comes back to the multifocality of prostate cancer. In a study that was done by my former mentor, Gary Miller, when he looked at these high-grade tumors and multifocality, what he found was multifocal lesions were very, very common, and the largest tumors were those in which a prostate only had one cancer. Okay, you had one cancer, you usually had the largest tumors, and if you had multifocal, they were smaller. Well, what does that mean? That probably means that the one tumor, it's all grown together and combined into one, and so that may explain the heterogeneity of origin that we get there. So you do get distinct clones, versus having a very small volume, which is likely one clone that came out. It's probably going to be not as heterogeneous.
Will a cancer that's arisen as a high-grade tumor out of the gate have the same profile as a cancer that has achieved the high grade through stepwise evolution, or is there commonality?
We don't know. I mean, that's something we really need to know.
It's a whole another hour lecture.
Yeah.
But we better stop now because it's 8 o'clock. And Scott, thank you for a great overview that shows that evolution, understanding morphology still. I guess that's where
our
the
job
interests here are.
should never get satisfied with where we are in medicine and science.
Great, thanks, Scott.